Hi, I'm Lori from HIS Talk. Welcome and thanks for joining us for today's HIS Talk webinar entitled Enterprise Data, Tapping Your Most Critical Asset for Survival. It is brought to you by Encore, a Quintiles company. Attendee phone lines have been muted to prevent background noise. You can use GoToWebinar's questions box in the console to submit questions to our presenters at any time. The presenters will answer your questions during Q&A at the end. Today's webinar is being recorded, so you'll receive a link to the recording as well as one to a PDF version of the PowerPoint presentation. We have two speakers presenting today. First up is Randy Thomas. Randy is the Associate Partner responsible for Performance Analytics at Encore, a Quintiles company. Randy has over 25 years of experience in healthcare IT with a focus on analytics and the reuse of data to support the performance improvements efforts of healthcare organizations. Joining Randy will be Jonathan Velez, MD, who is the Vice President and Chief Medical Information Officer for Hartford Healthcare. Dr. Velez provides system-level CMIO leadership for Hartford Healthcare, a $2 billion annual revenue health system consisting of 4 acute care and 2 behavioral health acute care hospitals, ambulatory multi-specialty physician practice groups, outpatient labs, and rehabilitation facilities. With that, I'll turn it over to you, Randy.
Thank you, Lori. And just so as this slide should have been up while Lori was introducing Dr. Velez and myself, so there's a little snapshot of what we look like. Just to review what we're going to be talking about today, there's really 4 topics. The first is it's all about the data and why now in healthcare do we need to focus on this issue of data. The second topic is beginning with the end in mind, a concept that we think is critical to supporting successful EHR implementations and optimization to ensure that the data that you want is available when you need it. The third thing we'll talk about is a word from technology and the fact that when you consider your data, technology isn't the only issue in town. And then finally, a little bit about keeping it clean. In other words, methods that you should consider implementing to ensure that you sustain data consistency and accuracy. So to start things off, I'm going to turn things over to Dr. Velez.
Thanks, Randy. And greetings to everybody out there, and great afternoon to you all. I'm honored to be part of this seminar here today, and hope that through some discussions about what Hartford Healthcare has been going through and the importance of data in that journey, that hopefully we'll be able to impart something that hopefully everybody can take back to their organizations afterwards. So really, I think just to set some context here, it's really important for us to first of all talk about this concept here at Hartford Healthcare called CareConnect. And really, as was mentioned previously, Hartford Healthcare, its anatomy today is really made up of multiple acute care environments, a large multi-specialty ambulatory practice. We have visiting nurse home care. And all of these organizations are presently on disparate systems, most of which do not talk to each other that well, if at all. What we recognized was that moving forward, we really wanted to provide a transformational patient care experience that not only allows us to meet the requirements of this move from volume-based compensation to value-based compensation, but one that does so while truly providing that kind of patient experience and that kind of patient involvement in the care that it's really going to be required to ultimately create the proposition directly to the patient population as well as the providers. And we recognize that in our current state, our anatomy was quite good and quite conducive to being able to do that, but our physiology wasn't exactly where we needed it to be. These disparate systems really make it difficult for patients to move from venue to venue, and as such, that has caused us some headaches and not allowed us to perform to the way we need to, and the way we've promised our community we will. And so really we developed this CareConnect program to take care of at least the infrastructure requirements to do that. And really this is exactly the way we pictured it. We pictured that we're kind of on the wrong side of the river, and we want to get ourselves over from where we are today in our current state capabilities to a place tomorrow where we totally transform the way we provide care into a very integrated experience for patients from one end to the other, regardless of which venue within Hartford Healthcare you find yourself. And as we thought about building that bridge, we really identified 3 spans to that bridge that are really important ingredients for us to be able to truly cross this river completely. One of those spans it revolves around our electronic health record. Moving from disparate systems to an enterprise system was incredibly important as a baseline step. The next thing we looked at was at imaging data, and we thought that there was really no reason for us to think of imaging data with patients any differently than we would think about any other data for patients in terms of how that flows with patients across venues. And so a sister program was created next to the EHR called ImageConnect. And ImageConnect is to imaging data what Epic would be to the rest of the patient's data. And the idea was to have that information flow with the patient and be available to providers through the EHR as opposed to having to go to different places, and using a common viewer that's easy to use and understand. And that it should include images that go beyond just radiology images to cardiology, pathology, and even up to wound care clinics and taking photographs of wounds for comparative analysis over time. But one of the things we also recognized was that while these information technology platforms were particularly good at gathering information, some of the things that we were going to need to do with that raw data moving forward was going to require capabilities that these systems weren't exactly as strong as they needed to be. And so we added a 3rd span, which is really around clinical analytics. And we figured that with these 3 spans, that will ultimately get us across the river. And one of the things that Randy will speak to a little bit later is it's one thing to build the bridge, it's another thing to then cross that bridge. And so we'll have more about that moving forward. But that's really the context behind which we look at our EHR implementation data. So what I want to do is I want to just basically focus in on the EHR and the clinical analytics for the purposes of this conversation. Randy, you can move to the next slide. And I guess the first thing that we really thought about was, and again this goes to the first question on the agenda, it's all about the data. One of the things we did as we began this journey towards the implementation of an electronic health record was really look and see, how are we going to implement this record, not just thinking about the actual implementation process itself, but thinking about what we intend to get out of that record on the other end. And that's incredibly important for us. We, like a lot of other organizations, have in the past done implementations that haven't necessarily thought about what we intended to get out of them. And then once some of these programs that are shown on the slide started coming out, we found ourselves a little unprepared. In some cases, we weren't capturing the data that was going to be required for these programs. And in other cases, we were, but we weren't capturing it in a discrete form that we could do anything with. And really, the first thing we did was take an inventory of the programs that we are currently involved in. This is more than what we're currently involved in, but the long and the short of it was we came to a few realizations right off the bat. And one of them was there's a lot of them. There's a lot of programs that are out there, and we're participating in quite a few of them. We also recognize that even though some can be cleanly classified as exclusive to the ambulatory environment or exclusive to the inpatient environment, quite a few of them actually overlap those environments. And then the final thing we recognized was not only was there overlap between inpatient and ambulatory type programs that we were involved in, but there was also an overlap amongst the programs where we found ourselves having to submit data around a particular key performance indicator to one program, and then that same piece of data was required for another program, which of course led us to believe that we would want to make sure that when we reported those, that we were reporting those and giving them the same answer on both sides. And we really thought then at that point that really, however we're reporting on these today, one of the things we want to make sure we are conscious of as we go into this implementation is really taking a look at what we need out. And data really became one of the key drivers for us in terms of developing our EHR implementation plan and making sure that we were keeping that at the forefront of our minds at all levels of the EHR implementation ahead of time, rather than finding out later on that we had a lot of cleanup to do. You can go to the next slide. One of those programs in particular I just want to call out and kind of level set in terms of how we view this. I'm calling out meaningful use here, but we could call it any one of these programs. We looked at these programs as really programs that were designed essentially to build muscle and to create discipline where maybe we haven't had those things previously. While the metrics that we're reporting on for meaningful use may not in all cases be agreed upon as being particularly meaningful, what was really more important to us and to our organization was to build those skills to actually do these kinds of reports, to build these kinds of key performance indicators such that moving forward, if we were going to tackle something that was internal to Hartford Healthcare, like for example preventing CHF readmissions, and we had certain key performance indicators that we wanted to monitor yet weren't the same as what was defined by CMS or elsewhere, that we would have the ability to very easily create those and be able to ultimately create metrics that we think are much more meaningful. So really, we looked at all these programs as really being more a floor than a ceiling. And really the goal here was, again, to really be conscientious then of the data that we're putting into the AHR up front to ensure that later on we'll be able to get that information out in a way that would be very helpful and ultimately produce an ROI. Next slide. So as we thought about this, we obviously recognized that we had quite a few programs that we were involved with. Some of these were programs that were regulatory in nature. Some of these were other quality initiatives that we were in voluntarily. And that in and of itself provided a significant amount of work to the implementation team as we continue to implement the electronic health record. But we also recognize, and I think everyone out there would agree, that all of us are sitting on an absolutely enormous mountain of raw data in our systems. And while there's a lot of stuff in those systems that we could harvest and refine into actionable information, not all of it is necessarily going to be the most important thing to spend your time on. And given the fact that the implementation has a finite period of build and testing, we certainly needed to find a way to match our implementation desires with what was really the most important priorities to the organization. And so in order to sort of avoid boiling the ocean or to create an implementation plan that lasted for years and years, we really wanted to, in addition to these additional quality programs that we talked about previously, talk about what else are we going to spend our time on at the beginning of this implementation. For example, we looked at registries. There's 30-plus registries we could create within the electronic health record. What we were really looking at is what should we do, what should we place at the top? Because quite frankly, for all of you who've created registries out there before, you recognize that this can be quite a time-consuming and tedious process trying to determine inclusion and exclusion criteria and the like. And that process can absolutely threaten the timeline of an EHR implementation or even an optimization project. So really where we wanted to start was first of all asking ourselves in the organization, what is it that we want to do? Just come up with a whole list of what it is that we'd love to do. Well, there's preventing preventable readmissions. There's CHF within that space. We want to have a better connectivity with CHF patients to cardiologists and closer care for a variety of reasons. Okay, that's great. What should we do then of all those things, given the other requirements that we have in the organization and other strategic priorities? And then getting a little bit more practical, what can we do? So what do we actually have the capability of doing from a bandwidth perspective, from a financial perspective, from a technology perspective? And then out of that then falls what we will do. And with that, we were able to take those specific initiatives and incorporate them into the project plan so that when we go and flip these folks off of their legacy systems onto the new EHR, that we will be able to tell them exactly how well they did. Or in the case that they're already measuring this out of the legacy system, to ensure that folks continue to see those measures after we go live and that they don't become transiently blinded because they're not seeing information they need to see before. And really the importance of this is in twofold. One is that you want to make sure that you're not boiling the ocean here. And for all the reasons that we talked about previously, you do have a limited implementation time, and quite frankly, you got a lot more data there than you necessarily have need for. And so putting data into an enterprise data warehouse or putting it through the whole analytics process is certainly not the thing to do for the sake of doing the process. So really, this is really key. And the other thing that I just wanted to mention on this slide, and Randy will talk a little bit more about this later on, is that this whole process of moving from what do we want to do to ultimately how we do, it really involves a huge aspect of data governance. And so as a result of that, we have set up a data governance system at the same time as we did the electronic health record, and at the same time as we're doing the implementation, so as to be able to take care of some of these things and make sure everyone's on the same page across the organization about what the priorities are and also how we define certain metrics that we're going to be reporting on. Next slide. So we mentioned previously, and I think this is important, that in all these different regulatory and quality initiatives that we find ourselves participating in, there is a significant amount of overlap between some of these programs. There are certain key performance indicators that do find themselves being required to be reported on out of a couple of different places, and of course sometimes we're reporting to the same organization, or at least the same subset of the same organization, and so discrepancies in those values would be very easy to find and obviously very embarrassing. And one of the things that calls then into view is the need for our data to be extracted in such a way as it can be repurposed and it can be reused over time. And so one of the things that we're also looking at during the implementation is not just what information do we need to have present in the electronic health record and present in a discrete format that we can then report off of, but thinking the next level, how are we extracting that information, normalizing it, and then placing it in a position to be reused for any and all of the different programs that we have to report in. And not only that, but be reused for things that we might want to do internally that we're not reporting to anybody. So really the idea is to be pulling these elements out of the source systems, creating these little repurposed elements that can then be pulled into population health, quality metrics, cost and operational performance, even payer analysis, and then ultimately be able to then take that information and then correlate into more significant reports regarding our clinical integration organization and our Medicare Shared Savings Pilot, among the other programs that we use it for. One of the things we really wanted to avoid was having to recreate that data wheel every single time that we needed a particular piece of information that was not otherwise stored in a repurposed sort of fashion. Next slide. So what I'd like to do is, we've been talking very philosophically at this point, but this is something that, I would invite you to take back to your organizations. You may already have something like this, but if you don't, feel free to take this back, use it to customize it to what's important to you. But really the long and the short of it is trying to take this conceptual discussion that we're having and put it down into practical steps that we use and that you can use to identify which pieces of data you're going to focus on during an EHR implementation or an optimization program, and to identify them from the point of, I think I need this piece of information, to, all right, I've got the information, it's pulled into a situation where it's accurate, it's reusable, and I can maintain it over time and make it available to other reports or other needs that are currently in the organization. And I would, rather than go through all the lists, I think that they kind of speak for themselves given the conversation we've had to this point. But I think this has been very helpful for us in terms of really making sure that we are getting very diligent about our data and truly treating our data as an asset in this organization, an asset that requires maintenance over time, an asset that needs to be built correctly up front, an asset that really ultimately is going to provide a return on investment moving forward. Next slide. And so really this is the analytics maturity model that we're following at Hartford Healthcare, and what I would say right now is that if I was being very generous, I would say we're probably somewhere around the foundational level here, but obviously moving towards the transformational level that we're looking at moving forward. We have been doing some analytics work both within our EHRs and outside of our EHRs for quite some time, and one of the things that we have found is that we do definitely have certain areas of expertise. But ultimately, in order to truly become transformational, we've got to be able to take those areas of expertise and in some ways bring them in centrally and make sure that we're all functioning through the same data governance model and building a once and for all repository of that information that will allow us then to move forward, not just with the regulatory and quality initiatives we mentioned before, but also the strategic initiatives of the organization. And that's really the track that we're forming. I would like at this point to turn things over to Randy to continue the conversation.
Thanks so much, Dr. Velez. Just wanted to pick things up with your comments about repurposing the data and making sure the data that you're capturing for EHR and potentially other applications is in that reusable format. And so, of course, this brings to mind that there's some technology that's needed to be able to support the analytics and the measurements. And before we talk a bit about technology, just want to introduce the concept that while technology is certainly not an easy or trivial aspect of data reuse for the reasons of analytics and measurements and reporting, it's part of a triad that also includes process and people. And the process and people aspects of effectively reusing data in an organization can sometimes be the more challenging parts of ensuring that you're getting the full value from the data that you've captured in your EHR and other systems. When you look at the technology options to be able to reuse your data, we think of it in sort of three different approaches. There's a kind of a commercial off-the-shelf approach, a semi-custom, a custom, and a hybrid. These approaches are can come in different delivery models. They can be cloud-based or SaaS or premise. They have particular focus on a data model. I'll go through that in a moment. There are considerations around your extract, transform, and load. In other words, how you're going to move the data out of your source systems into an environment where you can reuse it to support the kinds of analytics and programs that Dr. Velez referred to. And then very importantly, considerations around how that information is going to be presented or how the end users are going to be able to have access to information in a way that they can digest it and use it for purposes of supporting improvement across the organization. So when you look at commercial off-the-shelf, you're basically buying a package that's going to have the data model, some aspects of the ETL, and a lot of the presentation layer included in that. And these tend to be, there's any number. I'll give a few examples. These are not endorsements or recommendations. These are but just readily recognized examples of commercial off-the-shelf. You've got Health Catalyst and Humatica, Premier, Truven, among some of those vendors that have those offerings out there. A semi-custom approach uses a predefined data model that might allow you to have some local extensions, and where you are likely going to be focused on developing your own ETL, and likely also be focused on a lot of the presentation being developed specifically for your organization. Some examples of that are offered by some large vendors like Oracle or IBM or Teradata, just again as examples, not endorsements or recommendations. The third approach, which we don't see many folks starting out with, if they don't already have an analytics environment, is a custom approach where the data models are developed by the organization along with everything else that the ETL and all of the presentation capabilities. Finally, there's a more hybrid approach where an organization might license one or more commercial off-the-shelf applications and then maybe build some extensions around that to meet particular needs of an organization. And that you don't necessarily need to pick one of these approaches from a technology perspective and stick with that. You could start with a commercial off the shelf and move into a hybrid environment, just as an example. But the technology is one of the things to consider as you're moving into this new environment to really repurpose the data that's being collected in your systems. What you also might be dealing with is the fact that over time, your organization has created niche approaches to supporting the measurement and analytic needs of different departments across your organization. And what that can result in, and this is strictly an example, is that you may have multiple data sources. You might have an Epic EHR, you might have Loss and TrendStar, all kinds of different applications that are data sources. But then where you then move the data into a number of different data repositories, in other words, places where you're going to be running reporting and analytics against, that then use a number of analytic tools. And this sort of environment where you can even see a technology as a data source and a repository and an analytic tool or application is not uncommon, because it's just sort of the New England farmhouse. You know, once upon a time there was this nice tight little 4-room house that over time additions got added to meet particular needs, and before you know it, you enter the house and walk through a bathroom to get to a bedroom to get to the living room. And that's where many organizations are today. As you really focus on how you want to streamline your operations to really take advantage of the data that you're collecting and ensure the accuracy, consistency, and reliability of that data, start to streamline your data sources and really get down to just a few data sources that are then feeding very specific repositories that have particular needs, an EDW for your analytics and measurement, maybe an operational data store for day-to-day reporting, and you might have a straight line through in terms of supporting your more general financial reporting. And that, again, rationalizing the applications and tool sets that you're using against a single data repository, so that as you're supporting the multiple programs, both external programs as well as your internal performance improvement efforts, that you're doing that against a consistent and reliable data source. Of course, you're not going to get from where you are to where you'd like to be in one single step. So it's important to, and this goes back to Dr. Velez referring to how at Hartford Healthcare they've identified what's most important to the organization so that they can prioritize those analytic needs that then identify the data that's needed back to be captured in the source systems, but that also defines the requirements needed for whatever those initiatives might be. And this is just illustrative of what some priorities might be in an organization. And as you work through your priorities, you can define the requirements of what you need to report on or measure. You can identify the data using that data discovery approach that Dr. Velez referred to, profile that data so that you truly understand what the source data is and don't have any surprises, and go through the build-out to ensure that you've got the measurement and the reporting to support the particular programs in your organization. Now, when Dr. Velez was referring to how your organization, or how Hartford Healthcare in particular, was going through a prioritization process, he talked about how underscoring all of that was this focus on data governance. And data governance is really not a new discipline, of course, but is relatively new to being embraced by healthcare organizations. And it's because of this focus on the reuse of data to support measurement analytics and various programs and initiatives across the organization and for external purposes. And really the whole role of data governance in terms of keeping data clean is making sure that as data moves from those source systems into the various analytic applications to support these programs, that it is done in a way that it ensures consistency and accuracy so that you can have sustainable data quality over time. So data governance, and I'm just going to give a few brief examples of data governance, and this is really something we're going to be covering in even more detail in a subsequent webinar with Dr. Morgan, the CMIO from Carilion Clinic. But data governance is a discipline, as Dr. Velez referred to, implemented in the organization to ensure that you've got the focus and prioritization around the data that's important to your organization so that it's available to support what's important to your organization. So when you think about the iteration of starting with the decisions around implementing your EHR and making sure that data flows into an analytics environment for reuse and going through a continuous cycle of performance improvement where you're also going to be going back over time and optimizing certain workflows, for example, as you discover new needs for data that now need to be captured in your source system. Data governance is that mechanism in your organization that can help negotiate the decisions between ease of use and supporting workflow that has clinical and operational relevance with the need for structured reusable data to support measurement and analytics across your organization, because that's never a black and white, one and done kind of conversation. So that as you go about thinking about your data governance program, you're working toward bringing together not just an IT focus, but really an enterprise-wide approach to what are your needs for data and what are you going to put in place, what standards and practices will you put in place across the organization to ensure that you are sustaining those gains in data quality and reliability. When you consider what you need for a data governance program for your organization, it's not as if there is a single approach that works in a cookie-cutter way across all organizations. You really need to consider best practices in data governance, what the characteristics of your organization are, as well as different recommendations and conclusions around what an initial model might be. And all of these factors together can drive whether you need a federated, a centralized, or a hybrid model to support the needs of your organization. Now let me just spend 1 minute talking about the commonality and differences between these models. Across all of these approaches to being organizing data governance is this need for centralized executive leadership. That executive visibility across the organization that data is an important asset and that it needs to be decisions around data need to be thoughtful and consistent. That's present in all three of these models. The centralized model is the one many organizations in healthcare start out with, where they bring everything together across the different levels of data governance so that there is a real focus and consistency in deciding what the standards and the processes will be. Some organizations will start with a federated model where there is a, sometimes because of differences or disparity in geography or differences in types of organization, where there's still this centralized executive leadership, but then there's pods of focus across the organization where there is some autonomy in decision making. A hybrid model is found more often in other types of industries. We've yet to see one in healthcare. But one example, just so that you have a reference point for this, is one of our colleagues once worked for a beer distributor, and there are bottling label requirements across the country. There are some federal requirements, there are some state-level requirements, and in one state, Texas, there are even county-by-county requirements that are different. So that's an example where sort of hybrid, a very centralized approach, but then the need to have localized autonomy, even within geography, was important. So to put all of this together and thinking about, it's all about the data, beginning with the end in mind, something relative to considerations of your technology, but also looking at process and people, and ultimately a renewed focus in healthcare, or even a new focus in healthcare on data governance. It's really about ensuring that your organization has the data needed at a consistent level of reliability and quality to support the performance improvement efforts both internally as well as the commercial contracts in a more pay-for-performance, fee-for-value world, and the various external programs, whether it's meaningful use or Medicare Shares savings or any other of the other external performance reporting programs available, that you have the data, that as Dr. Velez referred to at the very beginning, there aren't surprises where you go to try and report on something only to find that that data is not available. So that concludes our prepared remarks for today, and we would certainly welcome your questions about anything Dr. Velez or I had to share. Lori?
Thanks, Randy. Now we'd like to open it up to the audience for questions. As a reminder, please use the questions section on the GoToWebinar panel to submit your questions to Randy and Dr. Velez. The first question, I believe, is for Dr. Velez. Doesn't following an EHR vendor's suggested implementation approach guarantee that data will be available for measurement and analytics?
It would be great if that was the case. Unfortunately, we find more often than not that that's not the case, and that's not necessarily by any oversight or necessarily ill will or the like from any particular vendor, but a lot of the HR implementations are still catching up with this methodology of really thinking about the data in such an integrated fashion as is required moving forward for analytics perspective, for the analytics requirements. So, you know, we've heard of examples of organizations getting pretty far down the line of these implementations and then suddenly recognizing that they didn't have this information available to them. And ultimately for us, we saw this as a huge aspect of the ROI of the system, and as such weren't going to be, you know, didn't want to get ourselves in that situation. So I'd love to say that the answer to that is yes, and someday it may be, and maybe consistently yes. But right now I have not seen that commonly, and it certainly wasn't built into our implementation plan to the extent we needed it.
Okay. The next one, was there a particular event that prompted you to consider data reuse as a significant factor in your EHR implementation decision?
So for us, what we basically found was that there were several programs that we were involved in that required us to, well, there are two things that really did it. One of them was the fact that we had several programs that we were involved with that actually did require us to submit similar metrics. And that's what we kind of knew kind of at the baseline. But what we had also experienced, not in that same realm, but in other realms across the organization, we would have people presenting particular pieces of data that are supposed to be answering the same question, but depending on where they may have pulled, which source system they pulled from, or where they, which data they consider to be more accurate or important than, say, someone else in another department, we'd come back with different answers to that question. Obviously, that doesn't give you the confidence that you've got the information that's truly actionable that will drive decision making. And I think you see that across a large organization enough times, and you recognize the need that, you know, there's two things that really solve that. One is data governance, as Randy was talking about, which is part of what drove us to go the data governance route. And then the other is really making sure that as you build into your analytics platform, your data in whatever data warehousing format you choose to do it, that you do it in such a way that people can come around later on and say, yeah, I've got this question, it's going to require this piece of refined data to answer, and I can just pull it off the shelf and be pretty darn sure that I'm going to get the same answer as somebody else moving down the path.
Okay. As your ecosystem grows, how do you plan to address variations in EMRs like community doctors as part of an ACO?
So our strategy at Hartford Healthcare is we actually have a couple of different prongs in that strategy. We do have a clinical integration organization. We call it Integrated Care Partners. Right now that's about 1,800 providers in total. And Integrated Care Partners is really one of those places where we can bring physicians together in terms of functioning as a clinical whole, while not necessarily requiring that the business model be exclusively an employment type model. Within that space, and of course across the whole organization and out to all the medical staff, we are offering to implement our EHR solution into their clinics as a way of not only just providing the ability to share information more easily, but also to also share workflows and best practices, such that when we recognize how the entire organization is performing clinically, it'll be easier for us to identify where the opportunities are for improvement, because there'll be less variability in terms of how people are doing these things. So certainly deployment of our EHR into that ambulatory space is one option. The other option that we are considering is obviously doing some sort of health information exchange with those organizations or with selected organizations to ensure that we can pass the information that's required for continuity of care. And then our analytics platform will be capable of aggregating data from multiple external sources to be able to aggregate to the center. That's obviously the most cumbersome way to do it, but it's certainly within the realm of possibility. So there's really a few prongs to how we intend to approach that problem.
Okay, thanks. That was our last question, so that will conclude this webinar. Before I thank everyone and say goodbye, I want to remind you there is a second webinar that takes off where this one left off, Data Governance, Why You Can't Put It Off, and that one is September 26th at 1 p.m. Eastern Time. Thank you for joining us today, and thank you, Randy and Dr. Velez, for an informative presentation. As a reminder to the attendees, watch your email for links to the recording of today's webinar as well as a PDF version of the PowerPoint presentation. We look forward to seeing you at our next HIS Talk webinar. Enjoy the rest of your day.